Hello, everybody. My name is Dr. Gunnar Elke from the University Medical Center in Schleswig-Holstein, Kiel, Germany. And I'm going to present you within the next 12 minutes which nutrition guidelines should we follow for our critically ill patients. These are my conflict of interests. And as I'm presenting on guideline issues, I have to mention that I'm the coordinator and first author of the German nutrition guideline, which I'm going to present as well. Actually, we as intensivists are chef de cuisine of the critically ill patient, taking care on the medical nutrition therapy, including the decision on how much energy our patient wastes, how many calories we have to give, how much protein we have to give the patient, and if we are going to feed him oral, enteral, or parenteral, and what about micronutrients. And we do that as we hope that we are going to improve clinical outcome by attenuating the ongoing catabolism induced by the critical illness and to avoid onset or the worsening of pre-existing malnutrition. So the most recent medical nutrition, abbreviated by MNT cookbooks, so guidelines for the critically ill patients, are coming from the European Society on enteral and parenteral nutrition, the ISICEM Society, and the German Society, which is part of the European Society. So two different guidelines published 2019. And a little bit older MNT cookbooks for the critically ill patients coming from the American Society and also from the European Society of Intensive Care Medicine, which I'm not really going to address because it's solely on enteral nutrition, and I'm wrapping up, let's say, within the next 10 minutes now, the strategies for enteral and parenteral nutrition. So to introduce you, all guidelines more or less address the different phases we are faced with as intensivists of the critically ill patients. So actually, it's more or less arbitrarily defined, but the patient, once critically ill, enters the so-called acute phase, which is divided into the early and late acute phase. And you see on the right-hand side the period, which is, let's say, highly inter-individual in our patients, but let's say more or less within the first week. And you can see that in the early acute phase, organ dysfunction is severe and progressive, inflammation is progressive, and the metabolism switches to catabolic, so muscle breakdown. While when the patient gets stable, organ dysfunction is going to get regressive. We are doing our best as intensivists to regress, to have inflammation regressive, and to that the metabolism state is switching from a catabolic to an anabolic phase. And after the acute phase, either the patient reconstitutes and recovers and enters the so-called recovery phase with resolution of inflammation, and the metabolism is fully recovered, meaning the patient eats and has an anabolic metabolism, so he can really tolerate the substrates we are giving him. And or the patient enters the so-called chronic post-acute phase with persistent immunosuppression and still ongoing catabolism. It's actually not quite clear when the post-acute phase starts, but we have determined the period of later than the acute phase, meaning everything post 7 days. So there's actually consensus among all three available guidelines, the ASPEN DGEM, so the German guideline, ASPEN guideline, on preferably use oral, then enteral, and then parenteral nutrition, that you should start when it's indicated medical nutrition therapy within 24 to 48 hours. You should ideally determine energy expenditure using indirect calorimetry, so measuring it. And if indirect calorimetry is unavailable, it's recommended to use simple weight-based equations, let's say within a range of 20 to 24 to 25 kcals per kilo per day, recommended by these guidelines. So actually in these issues the guidelines differentiate. So the topic of how to assess nutrition status and how to handle patients with pre-existing malnutrition, the recommended protein intake, and actually also the nutrition strategy and indication, or rather say the timing of parenteral, or let's say also supplemental parenteral nutrition. For the sake of time, I'm trying to also address the differences in recommendations for obese critically ill patients, and I won't have time to comment on the different recommendations for specific patient groups like septic patients, and also to address micronutrients and pharmacotherapy. So the German Nutrition Society recommends that at the time of ICU admission, the criteria for disease-specific malnutrition proposed by the DGAM, or the so-called Subjective Global Assessment, SGA, may be used to assess nutrition status. And we also address, although being aware that it might be difficult from center to center, to also use non-invasive serial examinations of skeletal muscle mass by ultrasound, magnetic resonance imaging, or CT when you have the local experience available. The ASPEN, it's quite easy. They say that every critically ill patient staying for more than 48 hours in the ICU should be considered at risk for malnutrition. That's quite easy. And they also address what you could do to clinically assess malnutrition, including anamnesis, report of unintentional weight loss, etc. The ASPEN, however, says that they suggest to determine nutrition risk using either nutrition risk screening, the RNS 2002, or the so-called Nutrix score that should be submitted in all patients admitted to the ICU. So the recommended tools for nutrition status assessment recommended by the German Nutrition Society are listed here. They either on the left-hand side are a potpourri of looking at the BMI and unintentional weight loss. And on the other hand, the subjective global assessment notes the history of the patient, including weight change, nutrient intake, etc., and including clinical examinations. And then the patient is categorized from A to C, from well-nourished and no decrease in food nutrient intake up to severely malnourished, severe deficit in food nutrient intake. The ASPEN also tries to recommend the so-called Global Leadership Initiative on Malnutrition criteria. That is, let's say, including a risk screening by using validated screening tools, then a diagnostic assessment using phenotypic and etiologic criteria. Then the diagnosis for meeting criteria on malnutrition should at least require one phenotypic criterion and one etiological criterion, and the severity grading is made up upon these criteria based on the phenotype you have from the GLIM criteria. The so-called Nutrix score is the recommended tool primarily by the American Society, and that is actually, in my opinion, and also listed in the German and European guideline, not really to assess malnutrition, but rather, let's say, a modified, let's say, disease risk score, including age, Apache 2 score, SOFA score, number of comorbidities, and pre-ICU hospital duration. So actually, let's say, no true nutritional marker, but this is recommended by the American Society. So the protein target in the acute phase, the German Society says that it should be 1 to 1.2 gram of actual body weight when you're talking about protein or amino acid intake. And they also recommend to compensate for the loss of amino acids in patients on intermittent renal replacement therapy. That should be added to the 1 gram baseline recommended protein intake. Whereas the ASPEN Society states that the protein intake should be as high as 1.2 to 2.0 grams per kilogram actual body weight, but the quality of evidence is very low. That's why the German Society decided to rather take 1.2 0 grams per kilogram actual body weight, respecting the results by the Leuven group in critically ill adults and pediatric patients. Aspen, let's say, is in the middle range. They state that during critical illness, 1.3 gram per kilogram protein equivalents per day can be delivered progressively for the acute phase. So then we come to the nutrition strategies, and that's where all three nutrition societies differ. So all three say, okay, evaluate nutrition status upon ICU admission by the criteria stated before in my presentation. The calorie goal, again, should be measured by IC or calculated by 24 kcal per kilo actual body weight and day. 24 is a little bit easier to calculate when you feed your patient continuously for 24 hours. You will see, and the protein goal, as I stated, is 1.0 gram per kilo per day and should be reached using a ramp-up approach until the end of the acute phase for 4 to 7 days. In all phases, you should prefer oral when it's not possible, enteral and then parenteral nutrition, and early supplemental or parenteral nutrition should be used when EN is contraindicated or fails to reach target and in malnourished patients, so already within the first week of ICU stay, and you should follow protocolized and individualized MNT according to the metabolic tolerance, let's say respecting a blood glucose, and when it's above 180 milligrams per deciliter, despite insulin greater than 4 units per hour, you should reduce or even stop your exogenous nutrient supply, and you should be controlling your plasma phosphate when initiating nutrition, and as soon as phosphate drops below 0.65 millimoles per liter, you should also again reduce your nutrition and substitute phosphate until it's in the reference range again. That's an algorithm we present, and I have already come to an end. The recommended nutrition strategy by Aspen is evaluate nutrition status upon ICU admission. Again, you should measure it first, then calculate by a simplified formula. The protein goal is a bit higher. And then they make a difference that you should rather use hypocaloric MNT within the first 3 days and then a ramp up to isocaloric MNT after day 3. When you only calculate your resting energy expenditure, you should use hypocaloric MNT throughout the 7 days. To avoid overfeeding, they do not recommend early full EN and PN within the first 3 to 7 days. And early and progressive PN should only be given in patients with severe malnutrition and non-malnourished patients with insufficient EN timing of SPN on a case-by-case basis. The Aspen consideration is important because they really stick to is it a high-risk patient or a low-risk patient, and in low-risk patient, you should only use trophic or full EN within the first week. I have to abbreviate my talk now and come to an end, but say that the Aspen is also quite reluctant not to use PN within the first week of ICU stay, only if the patient is at high nutrition risk and when he has a contraindication for EN. So my conclusion, skipping my recommendations for the obese patient, is that actually more or less there is consensus among the US, European, and German guidelines. Start MNT in general when it's indicated, prefer EN over PN, and measure ideally resting energy expenditure and not calculate it. Differences in the assessment of nutrition status, recommended protein intake, and the timing and nutrition strategy, especially depending on pre-existing malnutrition or not. The quintessence for my talk is feed your patients, protocolized and individualized, and respecting the metabolic tolerance. Thank you very much for your attendance, and stay safe. Best greetings from Germany.